Welcome back to The Proof and welcome to the Best of the Proof 2025 Part 2. As we close out the year, I want to wish you a very happy new year, a year of great health in body, in mind and spirit, plenty of laughs, and perhaps most importantly, a year that is filled with incredible memories that deliver dividends for years to come. In our last episode, Part 1, we revisited some of the biggest nutrition conversations of the year. We covered protein, seed oils, the microbiome, and more. Today in Part 2, we're turning to what all of that ultimately impacts. Heart health and blood pressure, including LDL, ApoB, and hypertension, how the way we eat affects the environment, what lactate and zone 2 training tells us about our metabolic fitness, how lifestyle can influence cancer risk, and where creatine really fits in when it comes to performance and healthy aging. Here we go. Best of the Proof 2025, Part 2. What is the optimal LDL cholesterol, blood pressure for the general population who is wanting to prevent cardiovascular disease as early in life as possible? What would you have told me to aim for if you had have spoken to me at age 15 or 20?
Optimal for LDL cholesterol for the general population, we'd have to start saying probably under 70 milligrams per deciliter or lower. Why do I even pick that number? It's because the number of less than 70 milligrams per deciliter, at least by studies done within the arteries, intravascular ultrasound, it's the splay point where we know that the disease begins to regress and the progression slows down. Now, from, again, realizing that's at age 20 or 30, we might not be able to undo the first 20 or 30 years of your life. And if the disease, atherosclerosis, has already started, we absolutely want to optimize your cardiac risk profile with lifestyle behavioral approaches so that LDL below 70, and LDL below 70 is a pretty tough hurdle for human beings. Through lifestyle and behavioral approaches only, even if they're vegan or vegetarian, because our cholesterol levels are not only determined by what we eat. Exercise has very minimal impact on the LDL cholesterol. It can raise the HDL, lower the triglycerides. Let's talk about blood pressure. Your blood pressure optimal is less than 120 over 80 millimeters of mercury. And most adult Americans do not have optimal blood pressure. It's typically young women who have optimal blood pressure, but many are in the already elevated blood pressure before they get to hypertension. From the Framingham Heart Study, we know even in that window between optimal and elevated, if you're living in that window for decades, it doubles your cardiac risk.
And what are the main risk factors that are driving that elevation in blood pressure?
100% of human beings carry the genes for hypertension. 90% of Americans will develop hypertension if they live long enough, and it is not a normal consequence of aging. 100% of humans have the genes because once upon a time, we didn't have abundance of food and we didn't have abundance of water. And so these genes were survival genes. You may have heard the concept of the thrifty genes. Populations that have been most recently exposed to starvation or famine often have higher rates of thrifty genes, and these can be the genes for prediabetes as well. What happens is you take those genes for hypertension and you place them into the modern environments that now are not only occurring in Western society, but are occurring in low and middle income countries as we are importing processed non-nutritious foods, and we're also translating unhealthy behavioral approaches, sedentary behavior, secondary tobacco use or primary tobacco use. And then we talked about some environmental factors. So we add those genes, and sometimes just gaining 5 pounds or becoming sedentary can begin activating those genes. Now you're not in the optimal blood pressure category anymore. You're now living with elevated blood pressure. And even if you're seeing a physician regularly, in the office, your blood pressure is, it's borderline or it's mildly elevated. Let's keep an eye on it. Let's work on your exercise more, physical activity, your weight, your diet, a DASH type dietary pattern, which has been shown to lower blood pressure. But over years of elevated blood pressure and the impact on blood vessels, both large and small, risk for vascular disease goes up over time. The blood pressure, the cholesterol, and then triglycerides, we haven't talked a whole lot about that, but our triglycerides are ambient cholesterol floating in and around our blood. And if each and every one of us, let's just say you and I had lunch together today, we ordered the same exact thing for lunch, but we started measuring post-lunch both our blood glucose and our triglycerides. There'll be a curve for each one of us of what happens to the glucose levels, the triglyceride levels, and that's determined by genetics. It might be determined by our physical activity, our weight. And for each and every one of us, if the blood glucose and triglyceride levels stay elevated for hours after each meal, and then they come back down, and then we eat again, and they go up and stay elevated for hours and come back down, this is risk over time. And we often miss that risk because when you go to your doctor, you might get a fasting blood glucose or even an A1C, which determines your mean glucose over the last 3 months. So we do have tools today where we don't have a triglyceride meter. It might be interesting if we had one to show what happens when we have a healthy pasta meal, maybe a glass of wine, and a good serving of vegetables and fruits. We think we're doing a good job. But we do have CGMs today, continuous glucose monitoring, which are approved for people living with diabetes. These CGM monitors, though, although they're not perfect, and they're not approved for people with prediabetes, they can be instructive tools to help us better understand the interaction between us and our food environment and our physical activity. And it can sharpen the edge on trying to improve lifestyle and behavioral approaches. The elevated triglycerides over time, it's taken us longer to understand the risk of triglycerides. But we think now clearly having repeated elevations of triglycerides or even a modestly elevated fasting triglyceride level, so coming back to optimal, you'd want your fasting triglycerides to be less than 100 milligrams per deciliter. That's pretty low. And then you'd want your weight to be optimal. It comes back to those life's essential eights and the biologic factors that are determinants of cardiovascular health, not cardiovascular disease.
You've probably heard the claim, if you're lean and metabolically healthy, high LDL cholesterol doesn't matter. In low-carb circles, this is more than just a claim. It's kind of a permission slip. Go ahead, load up on butter, bacon, and ribeyes. After all, you're in ketosis, right? But here's the real question. Is that confidence backed by science? Or just wishful thinking wrapped in six-pack abs? A new study, the Keto CTA trial, set out to explore this very question. It followed 100 people on a long-term ketogenic diet, all with significantly elevated LDL cholesterol and ApoB, using coronary CT angiography to track changes in their arteries over 12 months. On the surface, the results might seem reassuring. But when you dig into the data and the way that the data has been presented, a more complex and very interesting picture starts to emerge. Whether you follow a ketogenic diet or have high LDL cholesterol yourself, care about someone who does, or are just generally interested about nutrition and cardiovascular disease, this episode is for you. With expert insight from my friend Dr. Alan Flanagan, who co-authored a detailed critique of the study, we'll unpack what the research really found, how it's being communicated to the public, and what it truly means for the keto community. No hype, no hit pieces, just a clear-eyed, evidence-based look at the very first study to track artery plaque progression in lean, metabolically healthy people with keto-induced high cholesterol. The study we're unpacking, titled Plaque Begets Plaque, ApoB Does Not, longitudinal data from the Keto CTA trial, was published a few months ago in the Journal of American College of Cardiology Advances. In a nutshell, the researchers wanted to answer a very specific question. Are lean, metabolically healthy individuals on a long-term ketogenic diet, people with sky-high LDL cholesterol and ApoB, actually at increased risk of plaque progression in their arteries? To answer that, they tracked these individuals for 12 months using coronary CT angiography, a highly precise imaging method that lets us see plaque forming within the artery walls. Now, the hypothesis behind this study is interesting. The thinking goes, maybe not all high cholesterol is problematic. These folks aren't overweight, they have good insulin sensitivity, normal triglycerides, and low levels of inflammation. So maybe, just maybe, their high ApoB levels, high LDL cholesterol level is less dangerous. And given that there is a resurgence in the number of people seemingly adopting a ketogenic diet, there is growing interest in whether or not this hypothesis is true. In fact, and it must be acknowledged, people on a ketogenic diet commonly report losing weight, seeing an improvement in their symptoms, but finding out at their doctor's visit that their cholesterol is sky high. Typically, doctors advise them to change course, lower saturated fat intake, consider taking statins, the sort of standard playbook for high LDL cholesterol. But some patients push back. They feel great, they're lean, and so they ask, what is my actual risk? Here's the problem. Until now, almost all of our cardiovascular risk data comes from general population studies, which include people with obesity, diabetes, smoking history, etc. Not this niche group of healthy keto dieters with isolated hyperlipidemia. So that is the gap in the literature that the Keto CTA study aimed to fill. Before we dive into the results, there is some crucial context that you need to understand about how this study was designed. The first thing I want to bring to your attention is that despite the study title describing this as the Keto CTA trial, this was not in fact a trial. In clinical research, the term trial implies a prospective interventional study, typically with randomized allocation, control groups, manipulation of variables, for example, assigning to a diet or medications, an effort to determine causality, etc. This study involved none of that. The researchers took 100 subjects already on a ketogenic diet, so they were self-selected, who met their inclusion criteria, which I'll describe shortly. Measured their LDL cholesterol and ApoB and plaque at baseline with a blood test, performed a CT angiogram and a coronary artery calcium scan, and then followed them for 12 months and remeasured these things. In fact, the authors pre-registered the study as an observational cohort, not a trial. So calling it a trial in the title feels misleading. This isn't just academic nitpicking. It really does affect how the public and the media interpret the results. So who were these subjects in the study? Essentially 100 self-selected keto dieters, all with very high LDL cholesterol, but otherwise normal metabolic markers. People who had been following a ketogenic diet for at least 24 months with an LDL cholesterol of 190 milligrams per deciliter or higher, who had otherwise healthy blood lipid and blood glucose results, HDL cholesterol, triglycerides, fasting glucose, etc., and normal inflammation levels, normal blood pressure, without a history of metabolic disease, without genetically elevated cholesterol, and these subjects were not taking medications or supplements that affect cholesterol levels. So we're talking about a very specific subset of people, of the population, sometimes referred to as lean mass hyperresponders or LMHRs. Importantly, the researchers were primarily interested in the percent change of non-calcified plaque volume, or NCPV as it's abbreviated, and as it will come up in this episode quite a lot. Essentially, as the name implies, this is the total amount of plaque that is not calcified in the artery wall, which can be measured with a CT angiogram and modern software like Clearly, which they used in this study. And it's this soft plaque which is more vulnerable to rupturing and causing a heart attack or stroke than calcified or hard plaque. By doing a baseline and then a 12-month scan, they were able to see how much this soft plaque increased by. The secondary outcome was percent atheroma volume, whereas non-calcified plaque volume measures the absolute amount of plaque in millimeters cubed. Percent atheroma volume tells us what percentage of the artery wall contains plaque, calcified and non-calcified, essentially standardizing for vessel size, allowing for better comparisons between individuals. The researchers also reported associations between ApoB, LDL cholesterol levels, and plaque progression, and made this a focus in their abstract and discussion. But these analyses were not pre-specified in their study registration. That means that they are exploratory. They're interesting, but not something we can draw firm conclusions from. So to recap so far, we've got a unique group of healthy, long-term keto dieters with very high cholesterol. A 12-month observational study using cutting-edge imaging to track plaque progression, and a hypothesis that challenges mainstream cardiovascular risk models. But there are already some concerns, particularly around how the study was described as a trial and how results were presented and discussed. And with that, let's discuss the results and how they were presented, starting with the abstract. Right away, any researcher paying attention would notice something odd. The abstract and the title put a spotlight on ApoB, but here's the catch. As mentioned, ApoB wasn't even a pre-registered outcome. That alone is a giant red flag, but it gets worse. Further, and perhaps more importantly, other than saying ApoB level didn't correlate with change in non-calcified plaque volume, there was no mention of non-calcified plaque volume. That is to say, change in non-calcified plaque volume, the primary outcome, as measured in millimeters cubed, was not mentioned. In fact, it wasn't even mentioned in the paper itself. Let that sink in. The primary outcome of the study, the change in non-calcified plaque volume in millimeters cubed, either as an average or a median, was not mentioned in the paper. Not in the abstract, not in the results, nowhere. Despite the authors acknowledging this omission and saying it was a, and I quote, sincere oversight, not intentional or selective reporting, end quote, it still has not been corrected in the original manuscript. The authors did provide the primary outcome data on social media and in a recent response to a letter to the editor following what can only be described as public dismay. So what did the data actually show once it was finally revealed? It turns out the median change in non-calcified plaque volume was 18.9 millimeters cubed, and the mean change was 31.5 millimeters cubed. Now, to put that into perspective, a separate study using the same Clearly imaging software reported a median annual non-calcified plaque volume progression of just 4.9 millimeters cubed in healthy individuals not on lipid-lowering medications. That means the subjects in the Keto CTA study who were lean, supposedly metabolically healthy, and keto adapted showed nearly 4 times the plaque progression compared to normal, healthy individuals over the same period and using the same AI software to measure plaque progression. And that's not all. We also have data from subjects without obstructive coronary atherosclerosis and without diabetes who experience a reduction in non-calcified plaque volume over 12 months when taking optimal medical therapy alone, a mean change of minus 21.3 millimeters cubed, or optimal medical therapy plus the DASH diet, a mean change of minus 51.3 millimeters cubed. Let that comparison sit for a second. Seriously, People on a keto diet, lean and healthy, saw plaque grow by 31.5 millimeters cubed. That was the median, while those on conventional therapies actually shrank their plaque. Even more telling, the keto CTA researchers themselves had predicted only 7 millimeters cubed progression, citing the fact that their cohort was substantially younger with little to no risk factors. So when the actual number came in at over 4 times that estimate, it raises some serious questions. Now, some folks might push back here and say, well, we shouldn't compare non-calcified plaque volume between subjects. We should be using the secondary outcome, percent atheroma volume. Well, when we do that, we see a similar story. In this study, the baseline percent atheroma volume was 1.6%, and the median change in percent atheroma volume over 12 months for subjects was 0.8%. Here's what Dr. Alan Flanagan had to say about this.
Where they stratified individuals based on their cardiovascular risk score into 3 different groups. They had a low risk strata, an intermediate risk strata, and a high risk strata. This was based on 10-year atherosclerotic cardiovascular risk scores. So the low risk less than 7.5%, intermediate risk 7.5%, high risk over 20%. And so for context, the annualized rate of percent atheroma volume change in this group, in each of these risk categories, was 0.99% for the high risk group, 0.45% for the low risk group, and 0.58% for the intermediate risk group. So this group that they have self-proclaimed as metabolically healthy individuals have a greater rate of progression than the low cardiovascular risk group and paradigm and the intermediate risk group. And their actual rate of change is closer to what we observed in the high risk group. And when we look at the relationship between annualized change in percent atheroma volume and risk of future major adverse cardiovascular events observed in the same paradigm study cohort, the rate of change of 0.93% in PAV was associated with a 23% higher risk of future cardiovascular events. So they are closer to that than they are to low risk. And so to describe these individuals as metabolically healthy, and I think we can apply a criteria here because you might be familiar with this concept of metabolically healthy obesity, which was a kind of a debated topic in the literature for a few years. And part of the problem with the definition, it was based on metabolic syndrome criteria. But part of the problem with the suggestion that there was this true phenotype was that often, because there are 5 metabolic syndrome criteria, the definition for metabolically healthy allowed for the presence of 2 elevated risk factors. As someone with 2 elevated risk factors, hypertension and, high C-reactive protein or some, anyone with 2 elevated risk factors is not healthy. And I think that we now need to apply the more stringent definition that people have started to apply in that area, which is 0 elevated risk factors, to this concept of this phenotype. And if we are truly to designate these individuals as healthy, then we should not be seeing the rate of plaque progression over 1 year that we've seen.
Now, the authors have stated that anything at or below a percent atheroma volume increase of 1% is not considered rapid plaque progression. Specifically, they've stated, and I quote, "The majority of the participants showed percent atheroma volume changes below the agreed upon definition for rapid plaque progression of greater than 1% per year." End quote. I looked at their reference for that, and frankly, the paper itself does not reflect their position here. It says, and I quote, "There is no established threshold for significant plaque progression as assessed by volumetric computed tomographic plaque quantification of the entire coronary tree. Future studies are warranted to establish a clinically relevant threshold of total coronary plaque progression by serial coronary CT angiography assessment." End quote. So my question to the authors here, Nick Norwitz, Dave Feldman, Adrian Sotomota, Matthew Budoff, etc., agreed upon by who? Firstly, per your reference, I do not see clear agreement that a percent atheroma volume change of greater than 1% is considered rapid, and anything under that is not. Secondly, even if there was agreement, this doesn't mean that an annual change in percent atheroma volume of 0.8% is low risk or represents stable plaque. Just because I'm not sprinting doesn't mean I'm standing still. I could be jogging very quickly. The bottom line here is that any threshold is likely arbitrary. It's not just below 1% equals no risk and above equals rapid. Whether we look at the non-calcified plaque volume or the percent atheroma volume data from this 12-month study and compare it to other cohorts, there is need for significant pause. While there certainly may be a few outliers, and there is, which the authors have been sure to point out, we should not be distracted from the fact that this group does not appear to be, on the aggregate, doing very well. Plus, a 0.8% increase in percent atheroma volume was just the average. 43% of subjects had a percent atheroma volume much higher than this, as Dr. Alan Flanagan describes here.
For this group that love to stress heterogeneity, this 0.8% change in percent atheroma volume was in the overall cohort, but they also considered levels of PAV progression in individuals in the Keto study that had a 10-year risk score of over 5%. So this would be akin to the intermediate risk group in Paradigm, who had a percent atheroma volume increase of 0.58%, annualized increase. The Keto CTA 10-year risk score of over 5% showed a PAV increase over 1 year of 1.4%. And the Keto CT participants who had evidence of CAC at baseline had an increase in PAV of 2.4%. So if they want to make this point that there is heterogeneous risk in this phenotype, then it's not necessarily incorrect. But all it is descriptive, not inferential. And importantly, this heterogeneity is observed in the context of at least intermediate, if not high risk, of percent atheroma volume plaque progression over 1 year. So it's not heterogeneous, but in the context of low risk, but for apparently one individual who had some sort of decrease. But on average, stratifying whatever way they cut it up, there is an increase in PAV progression that, as it relates to risk, is a cause for concern. And they have framed it in a way that is utterly incongruent with scientific integrity relative to the data that they have.
I recently ran my full labs through Function Health, and I have to say the results were eye-opening. Turns out my ApoB was higher than ideal, probably thanks to a little too much coconut yogurt. I also found out I was slightly low in copper, something that I would have never suspected without testing. On the flip side, my biological age came back 13.3 years younger than my actual age, a calculation based on the work of aging researcher Dr. Morgan Levine. So all in all, I've got a few tweaks to make to optimize my lipids and nutrient status, but overall my blood work says I'm doing pretty well. That's what I love about Function. You get access to over 160 biomarkers covering everything from hormones and inflammation to nutrients, toxins, cardiovascular risk, and more. And all your results are housed in one beautiful platform, all tracked over time. Once you get your results, you can make informed changes before small issues become big ones. To get started, head to functionhealth.com/Simon Hill. The first 1,000 people get a $100 credit toward their membership. That's functionhealth.com/Simon Hill. This might be a little bit of semantics before we get into the kind of potential treatments here. If we think about the diagnosis of cardiovascular disease in the United States, is it that anyone who has some non-calcified plaque volume, soft plaque building up, has cardiovascular disease? Or is cardiovascular disease as a diagnosis reserved to someone who has had a clinical event?
Yeah, I always say it depends who's asking. So if somebody is, if I'm talking to a patient and they want to know if they have atherosclerotic cardiovascular disease, I say I'm not really comfortable calling it a disease, but I am comfortable saying you have atherosclerosis. Here we've identified it with this imaging test. But if, for example, I need to leverage a diagnostic code in order to help them get therapeutic that is limited based upon a diagnostic code, I'm willing to use that code more liberally to help my patient. So depends who's asking.
Yeah, I guess part of my interest in that question was a lot of people are not doing imaging. So I wonder how many people would have atherosclerosis or atherosclerotic cardiovascular disease without even knowing, given that that this disease process, I believe we've spoken about, Tom, often starts, I mean, you mentioned before, in utero, early life.
Yeah, that would be a real genetic cause, homozygous FH, or so that the mother would have that, and if the kid had it, would be in utero atherosclerosis. But as this new Turkish study showed, looking at the abdominal aortic thickness, and we know from previous studies, P-Day, Bugalusa heart, the young kids who unfortunately got killed from some other reason, trauma or whatever, when they autopsied them, there's fatty streaks in their aorta at ages 4, 5, and 6. We certainly know from the Korean War and other studies that young adult men who died are shockingly the amount of atherosclerosis. So it's an immense epidemic that's out there. And this is why in that age group where it's a little easier to get imaging nowadays than it was easier, especially the CAC score. The CTA is a little more expensive, of course. You have to just really, the family history, as Dan mentioned, other historical things, a good physical exam, but it's the biomarkers that we're doing short of imaging that I think is the only way you can say, I got to jump on you earlier.
I think, atherosclerosis is, I think you can describe it as ubiquitous. There are individuals who have no signs of it, but I was referring to that nomogram from the CCTA study, zero atheroma volume diverges from zero at age 45. So after age 45, the 50th percentile is you have measurable atherosclerosis. And I think you were getting at, should you were lucky enough to have access to this test, was it worth doing, or could you have been managed without it? And I like Tom's answer. I would add that I'm happy to manage the care of my patients if they can't get imaging. But if they can get imaging, I always have a higher degree of certainty about what I'm doing. Otherwise, I'm kind of treating them with my eyes closed, and we oftentimes have to take the approach, well, let's treat more heavy than we need to rather than back off. So more information enables you to be more precise about intensity of treatment.
Something that I've observed through dietary changes is that I, for whatever reason, appear particularly sensitive to saturated fats. Even more recently, I increased coconut products in my diet, which are quite rich in saturated fats, and I saw my LDL jump up. And this aligns with the dietary changes I made at age 29. I moved to a much higher fiber, lower saturated fat, higher polyunsaturated fat diet, and my LDL cholesterol responded really, really nicely. I'm asking you to speculate here, and I appreciate it. It may be difficult on an individual level, but if I didn't make those dietary changes, do you expect I would have had much more plaque on my CT angiogram or more calcification?
Like you said, who knows in an individual patient, but the guess would be, the worse your biomarkers that we rely on, the more likely you would perhaps have a little bit more plaque in those arteries or so, sure. And that would be a big smack in your rear end that keep up the good lifestyle, because it seems to, you probably would be worth. And if you weren't on a lifestyle, we would certainly be big part of our therapeutic advice to you.
Yeah, it's hard to guess prospectively how things would be, but we can use the retrospectoscope from clinical trials to see what happens when we manipulate something and see what happened to the population. And, the big outcome that we pay attention to is not so much, plaque volume, but rather cardiovascular outcomes, like how many cardiovascular events can you prevent if you do intervention X versus placebo. And I think the closest thing we have, I don't think we have CTA data yet on changes in plaque volume, at least not robust data, but we have some IVUS data, intravascular ultrasound data, that tells us what happens to plaque in people who have established coronary artery disease, like lots of plaque, not necessarily somebody with your degree of plaque. You have a low level plaque, but someone with a more extensive plaque, what happens when we intensively lower their LDL cholesterol? So we can maybe extrapolate those findings to somebody with your biology, but I think your biology would be different than somebody who has multivessel, fibrotic, calcific, extensive multivessel disease. I think it's different biology, and we should have different expectations.
Let's talk about ApoB target for stopping this process, slowing it down, or maybe even getting some regression. Tom, I know you love this question. What ApoB level should I aim for through lifestyle plus medicine to reliably halt the plaque progression or potentially induce regression?
Well, my 2 lines of evidence, which will support what I would recommend, is I already mentioned the hypobeta, the genetic hypobeta, people who the day they're born have a very low ApoB LDL cholesterol and remains that way throughout life. They just don't get atherosclerotic heart disease unless they're at the upper ranges of that ApoB or so. So that would be one reason, and make your ApoB under 40 milligrams per deciliter. But, Brian Ferentz is the lead author. I think it was one of the European guidelines, and looking at Mendelian data, observational data, and all the randomized controlled trials. And he even showed that starting with an LDL cholesterol of 70 or 78, if you keep dropping it below there, those lines almost went down to 0 as far as the event rate or so. So it's lower is better. That is not debatable anymore. We add now the adjective lower is better, and the longer it's lower is better. So I would shoot for an ApoB. Certainly, you want to take the 5th percentile, 60, but again, your family history, there's no harm in making your ApoB 40. There's no downside to it. Depending on where you start, you're going to get in more and more pharmacology, and some of those could be expensive, but you could start simple and see where you get. And with a couple of generic drugs, you might be able to bring your LDL cholesterol and ApoB down to those levels. So that's where I'm going. I'm making you a hypobeta.
So I'm glad you brought up the Mendelian randomization data. It's super interesting. So, in clinical medicine, we rely so much on cardiovascular outcome trials. And most of our cardiovascular outcome trials are approximately 5 years. And in recent years, they've been abbreviated by making them much larger trials so that they can get the information in 3 years. So, larger database, you can sometimes get information a lot sooner. And some of our studies maybe go as long as 7 years. And then they'll do something like an open label extension just so you can get a little bit more data than that. But most of our data comes from these very short cardiovascular outcome trials. So a Mendelian randomization trial compares to that and enables us to imagine what would happen if you had a genotypic variant that gave you a specific phenotype, like an LDL cholesterol that's 10% lower than the average person in your population. But instead of imagining that as over 5 years, that's, you look at someone who's 50 years old with that genotype and who's had that LDL cholesterol lowering for 50 years. And you compare them to the population rates of cardiovascular events, and you see an outsized proportional benefit from very small LDL cholesterol lowering compared to the general population, suggesting that there's compounded benefit from prolonged, even small reductions in LDL cholesterol. Now, most of our cardiovascular outcome trials don't look at small reductions. They look at large reductions. We like our drugs to lower LDL cholesterol by 20% at a minimum. 50% is even better. And now we have drugs that can lower LDL cholesterol by 60%. And so you can get a greater short-term cardiovascular benefit and a long-term cardiovascular benefit we extrapolate as being even more pronounced because you get so much more lowering. So that informs the lower is better and longer is better. But those are cardiovascular outcome trials. If we're looking at if we really want some other information about what's happening at the arterial level, that's where I really think the IVUS data is really neat, because you can see what's happening at the micro level using intravascular ultrasound and look at the plaque changes in a short period of time. And the data set that I think is really interesting is that Glagov remodeling study, where they looked at the intervention adding evolocumab, which is a PCSK9 monoclonal antibody, on top of high intensity statins. So a high potency LDL lowering therapy on top of another high potency LDL lowering therapy. And what you see is that when you get LDL cholesterol levels down to about 90 milligrams per deciliter, all you've done is kind of slow the progression of plaque. But in these high risk patients, if you get it between about 60 and 90, you seem to be able to stop plaque from progressing. It really flattens out in the IVA studies. But it's not until you get below 60 that you see some actual plaque regression at the microscopic level. You're not talking about changes in the lumen diameter, but you get these microscopic regression. And so that might be something that we can extrapolate to your care, Simon, right? You don't want just to do okay. You're trying to really fix your arteries and make them as stable as possible for as long as possible. So I think targeting LDL cholesterol levels below 60 for you is a very reasonable thing to do. And if you want to take the time, I can tell you how we use ApoB equivalents from that data set too, like where the numbers.
Yeah, please. Yeah, the what would the equivalent ApoB target be there?
It's a busy answer. So the relationship between LDL cholesterol and ApoB varies depending upon the metabolic circumstances. So as Tom has taught me and the rest of the world, one of the key regulators of that process is upregulation of an enzyme system called CETP, cholesterol ester transfer protein. And, so what you get is a, lipid exchange between lipoproteins, and you get remodeling and differences in size and cholesterol content of the lipoprotein. So when, certain circumstances will upregulate that process and change the size and the cholesterol content of those particles. So there's potential differences between LDL cholesterol and ApoB, even though they're meant to represent the same thing, right? They're meant to represent the amount of atherogenic lipoprotein in circulation. When you treat somebody with medicine, the liver, the medicines that we use, the LDL receptor on the liver upregulates and starts more efficiently removing LDL particles from the bloodstream. But there's a greater affinity for the cholesterol-enriched LDL particles. So when you treat people, the LDL cholesterol goes down out of proportion to the number of particles that are being removed. So LDL cholesterol goes down more than ApoB when you give people medicine. So we, in the NLA statement from last year, where we looked at the role of ApoB in clinical management, we actually created two separate relationships, two separate linear regression analyses for treated versus untreated patients. And they were two separate because of this phenomena of what happens when you treat people. So if we look at ApoB goals in our treated patients at the lower end, the relationship is if you're using an LDL cholesterol threshold of 55, where you would do more if your LDL cholesterol was greater than 55, the number of ApoB that we would use as that threshold is 60 milligrams per deciliter. And Anne-Marie Navarre's group did a simultaneous evaluation. They saw the same numbers and they thought, you know what, it's simpler to just say 55 and 55. Just, they're so close together, it's okay to just use the same number. But for precision, we did distinguish between them.
Right. So for someone like me, my ApoB, when I'm pretty strict with my diet, sits at, let's say, 70 milligrams per deciliter. I need to get that down by 25% or so, whatever it works out to be, to get below 55 milligrams per deciliter. And that's a point that you guys are saying would halt the progression and perhaps lead to some microscopic regression.
Yeah, but as Tom pointed out, I'd rather you be closer to 20 than 55.
Yeah. So again, there's no harm at dropping it from 55 to, and if we can do that easy enough without using one of the big guns, like you said, a PCSK9 inhibitor, fine. But even if we couldn't and you wanted to do that, then it's your decision. Do I want to twist somebody's arm to get a third-party payer to cover the more aggressive drugs, or am I willing to pay that for my vascular health? That's always an individual decision.
Tom, can you remind us, this is something we've spoken about, and I know people in the comments will say, but gents, all of our cells need cholesterol to produce hormones and for cell membrane fluidity, all of these things. And I do understand if someone doesn't understand the physiology, where that concern can come from. I think there also are people that know better that just say it to confuse people, quite frankly. But you mentioned there that there's no harm in going lower, like say down from 50 to 20. Why is that, given how important cholesterol is for our cells?
Look, cholesterol is obviously an essential molecule for human life. It's in every cell membrane in our bodies, and without cell membranes, no cells. Therefore, I always phrase it this way: evolution went to great power to make sure every cell in your body could de novo synthesize all the cholesterol it needs for whatever it's in its cytosol and in its cell membrane. And it even knows that above a certain threshold, cholesterol molecules are toxic because they can crystallize. It also gave every cell the ability, a tool, a membrane efflux transporter to get rid of any excess cholesterol. So cells, if you look at what we call cholesterol homeostasis, is it in balance? Every cell doesn't need help. But there might be one or two exceptions to that. Now, when I'm talking with cells, there are two types of cells in your body: brain and everything else below the brain. That's called peripheral cells. But even the brain and all the peripheral cells make all the cholesterol they need. Ergo, they don't need a delivery of cholesterol. When we measure cholesterol, we're measuring cholesterol that's circulating in the plasma lipoproteins. We're not measuring any tissue cholesterol level or so. So we have to extrapolate from a plasma cholesterol level. Are we injuring or hurting a cell by depleting plasma cholesterol? And if you listen to what I just said, cells don't need a delivery of cholesterol, then no, we're not. Basically, most of the cholesterol in plasma is within your LDL particles, and we now know their primary purpose is to bring cholesterol back to the liver and likely the small intestine, clearance of the ApoB particles, and then those organs, the intestine or the liver, can do other things with the cholesterol. HDLs carry the next largest amount of cholesterol in your body. And where are they going? For the most part, they're going back to the liver or the small intestine. But HDLs have the ability to deliver cholesterol to a couple of cells that might need extra cholesterol, and that would be your steroidogenic tissue. Again, for the most part, they synthesize all the cholesterol they need. They don't need a delivery. But if they do, they can upregulate something called the scavenger receptor, which delipidates cholesterol from the HDL, and they get an extra supply, maybe in an urgent situation, especially adrenal cortex, where they got to start shooting that cortex. And the other tissue that can upregulate those scavenger receptors and take cholesterol from an HDL is the storage organ in the body for cholesterol, are adipocytes. Now, LDLs don't deliver cholesterol to adipocytes unless in extreme emergency. LDLs do not deliver cholesterol to steroidogenic tissue. They could. Those cells could upregulate LDL receptors, but they rarely do. So the cholesterol in your plasma cannot be used as an indicator that I'm hurting a cell. The last thing I'll say is, because I get tweets every day, you're shrinking your brain when you drop LDL cholesterol too much. Your brain, starting in like the second and third trimester in utero, and certainly from the day you're born, synthesizes de novo all of the cholesterol it needs. It doesn't get a single molecule of cholesterol from anything carrying cholesterol in your plasma. So we've proven this in clinical trials. If I make your LDL cholesterol 15 because you're a nightmare and I want to make your ApoB or LDL cholesterol that low, I cannot hurt any cell in the body by depriving them of cholesterol. I'll shut up after that bit of a diatribe. So you can't use plasma LDL cholesterol as a sign you're injuring something else.
My days can get pretty full on. Podcasting, research, training. So I'm always looking for simple ways to slow things down and anything that can support recovery. And one that has stuck of late is Peak's Organic Pu'er Tea. It's actually a fermented food, and that's what really sets it apart from green or black tea. Because it's fermented, it's naturally rich in pre- and postbiotic compounds that help support a healthy gut environment. If you haven't heard much about postbiotics yet, you will. They're really the next chapter in gut health. Beneficial compounds produced during fermentation that keep supporting you even after the microbes themselves are deactivated from heat. Pu'er tea is also rich in an incredibly powerful class of polyphenols known as catechins and transform into short-chain fatty acids known to have anti-inflammatory effects, helping protect ourselves as we age and reduce our risk of developing chronic disease. And what makes Peak's Organic Pu'er Tea extra special is its source, 250-year-old wild tea trees in untouched forests, some of the rarest and most nutrient-dense tea on planet Earth. Get 20% off site-wide for life, plus a complimentary holiday bundle at peaklife.com/Simon. That's PIQUE life.com/Simon. Who should clearly be on some type of ApoB lowering medication or a combination of these medications? And what is the ultimate goal of treatment? What are we trying to achieve here?
Let me start with the latter and then I'll get to the former. What we're trying to achieve is reducing LDL with medicine for those people who are going to stand the most to gain from LDL reduction in the shorter term, based upon the evidence that we have from like large cardiovascular outcome trials. And while I have sort of quipped to my trainees and to my patients that I'm willing to prescribe LDL lowering therapy to anybody who walks near me because they're so safe, in general, I only ever prescribe it to very specific population. I'm willing to broaden that. I'm not as rigid. I'm not confined by guideline strict interpretations, but the national guidelines have taken a great effort to synthesize the information from large-scale cardiovascular outcome trials that inform us when LDL and ApoB lowering therapies have the greatest impact on major cardiovascular outcomes like heart attacks, strokes, death, revascularization. And in 2013, perhaps the most rigid and most evidence-based foundational therapeutic approach that we have from that set of guidelines, they established that there were 4 basic groups that all, quote, qualify for lipid-lowering therapy. And at the time, in 2013, the only strong evidence was for statin therapy. Things have changed since 2013, but that's why it's such a statin-based regimen. So those 4 groups are adults with established cardiovascular disease who've had cardiovascular events in the past, adults with severe hypercholesterolemia in a pattern that's consistent with familial hypercholesterolemia, adult diabetic patients, especially when they have other risk factors for cardiovascular disease, and the rest of us, if we fit into a category where when we calculate the risk over the next decade for a cardiovascular event, that we are worthy of being on medicine, that for us, the benefit of the medicine outweighs the risk. So very low risk patients, based upon calculations, you may not necessarily prescribe medicine for, even if over the course of the next 30 to 50 years, they may benefit. In the next 10 years, there's no evidence that they would. And so those 4 groups are the basic 4 groups that we look at as, being eligible for a prescription for LDL lowering therapy.
So how do we balance that with the idea or concept that we've spoken about, Tom, previously, that physiologic levels of LDL cholesterol, perhaps they're like 50 milligrams per deciliter or lower, and that this is a disease that occurs over decades and decades, most people have an LDL cholesterol above that. We hear certain cardiologists saying lower and earlier the better, and emphasizing this idea of primordial prevention. So how do we balance, I guess, where the guidelines are indicating, kind of stepping in with LDL cholesterol lowering medications versus acting very early and being kind of super cautious with this disease process?
Yeah, so my advice is read the guidelines so you understand them, but then pretty much ignore them in the real world clinical practice. I want to point you to a just published editorial written by the president of the American Society for Preventive Cardiology, Mike Shapiro. And the title of that editorial was Rethinking the Starting Point. And that means we can't wait till your 10-year risk assessment is going to tell me you're at high risk. We have to recognize the causal biomarkers of atherosclerotic coronary disease very early in life, and then jump in with therapeutics, which could be lifestyle, but in many people it is going to be drug use at a much earlier age, and they would never qualify for drug use using any of the existing guidelines. So using my example that you quoted nicely, the hypobetas don't get atherosclerotic heart disease. Those that a good clinician can ascertain is at cardiovascular risk using a variety of biomarkers, imaging, not too much in the young person, family history, blah, blah, blah. We can, I think, going to have to start with therapies much earlier in life if we're ever going to take out this disease. People will start quoting number needed to treat and that sort of stuff that has no meaning to me. We start with the generic therapies. The cost is infinitesimal, and that is no longer a reason not to use the starting drugs. They're incredibly safe. Statins have been around for 38 years now, used by millions of people, tested in more clinical trials than probably any other class of drugs ever. The ezetimibe, not up to that par yet, but it's been around over 20 years now, and we certainly don't have any bad safety signals for that. So I think we're in pretty safe ground identifying earlier in life the people who need it, and certainly not waiting for a 10-year risk assessment, which is pretty much based on age or gender, and figuring out who to treat. So that's sometimes called, Dan will get a shiver up his spine, but medicine 3.0, thinking outside the box, but thinking intelligently.
Can I respond to that?
Of course, Dan. That's why you're here. You're here to chime
remember,
in wherever you want.
He's a former president of the NLA. He's got to talk in certain directions. I don't.
I'm quite comfortable going beyond the guidelines. I haven't quite gotten to the level where I say throw out the guidelines. But your point is taken, Tom, that guidelines are written by, especially the way they're written now, spearheaded by the AHA, ACC, and up to 10 other medical societies, so-called multi-society input. They're written by committee, so there has to be a consensus on decisions. They are fully established based upon randomized placebo-controlled clinical trials with cardiovascular outcome data and meta-analyses of the same. And so they have a very high evidentiary level to take into consideration the evidence. And so because of that, some of the concepts that you bring up about, 30-year data and other information like that can't find its way into the guideline. But in nowhere in the guideline does it say do not prescribe if someone's risk is calculated below a certain range. It just says that it tells us when to prescribe, not when not to prescribe necessarily. So it's not proscriptive. It's really prescriptive.
But most people do take that as a reason not to prescribe, at least those who want to quote the guidelines.
I agree. And the reality is that in a real world application, you do need some rules to live by. And a general rule of thumb of everybody needs a lower LDL and everybody should take medicine unless they have hypobeta lipoproteinemia, which I'm not saying that's what you said, but like that's way too liberal. As a matter of fact, you and I and Simon have talked about whether Simon should be on medicine, and we're not even talking about primordial prevention with Simon, and it's still an issue because he is has dedicated his life to nutritional practice. And there's some implications for a soon to be 40-year-old man with some plaque starting a statin drug that go beyond his own just personal needs. So life is complicated. Individuals definitely need options to use therapy, but they need some guidelines to use as the walls within which we make decisions. So I wouldn't. All I'm saying is I'm not ready to throw out the guidelines, but I want everyone to understand that just because it's not stated explicitly in the guideline doesn't mean you can't do it.
That's an important clarification. If I was to kind of throw a question back at you to bring this down to clinical practice, let's say we have a 30-year-old who's listening to this, who is low risk by definition, doesn't have diabetes. They haven't been scanned, so we don't know that they have plaque, but they have no prior history of a cardiac event, and they have no family history of cardiovascular disease, and no other risk factors like high blood pressure or smoking or alcohol or insulin resistance. But their LDL cholesterol is sitting at 125, 130. And I'm bringing this case study up because this is an example of a friend of mine. And he is wondering, should I use a lipid-lowering medicine? He's only 30 years old. He has modified his diet, but he's not really willing to modify it any further than where it's at. This is sustainable for him. And he's interested in whether the addition of a statin plus or minus some other lipid-lowering medicine is going to help him get into his 60s and 70s in better health at lower risk of having a cardiac event. And he's asked me that, and I've gone back with looking at the guidelines, and it's a hard question to answer when you look at the guidelines.
Well, it's not hard for me. This is a guy, again, using it's time to rethink and start. I see zero downside to start him on the type of initial ApoB lowering drugs that we just mentioned or so, and drop that down to a safer. I don't know that you have to take him to a hypo-beta level, but dropping his LDL-C, what'd you say it was, 120 down to 70? I see zero reason not to do that. Cost is not a reason. Side effects are not a reason. And what are you losing in the process there? So to me, that's those are the type of people we're missing now. That's the type of man when he is 40 or 50 and you do those LDL year calculations is going to be entering a threshold where his CTA looks like yours. So why wait?
That person comes to me and says, I'm willing to take a medicine. Do you think I ought to? The answer is, well, and you asked whether the guidelines suggest whether they should. The answer is no. The guidelines do not recommend use of medicine in that particular patient. But if that person says to me, I'd like to start a statin and or some other LDL lowering therapy, I have no problem with that for the reasons that Tom just described. But I wouldn't necessarily go out of my way to prescribe it for that person.
And you both emphasized a really important point that although the guidelines don't specifically indicate it for that person, they're not saying that it's not recommended.
Right.
So there is certainly a scope for clinicians in that circumstance to prescribe.
That's up to the clinician's office you walk into. And I would tell you in your scenario, the vast majority of physicians probably would not treat that person. And, it's like I go back to 1987 when statins came on the market and I started prescribing them like I was handing out M&Ms. And then there were people who would not use a statin until randomized blinded trials showed efficacy, which was 7 years later in 94. And I always joked they were burying people over those 7 years, and I was burying less people over those 7 years, waiting for the level 1 outcome evidence. And we're beyond that now. Level 1 outcome evidence, other than if you got some novel niche drug, nobody's going to spend the money to do. We could use a lot more randomized blinded trials looking at certain combination therapies and everything, but they're never going to happen with generic drugs because they're way too expensive. So I've heard Michael Davidson, another all-time lipid guru, say, we just have to look at other ways. Maybe it's imaging, maybe it is just biomarkers, extrapolating all the knowledge we've gained over the last 50 years and making decisions not based on level 1 evidence anymore.
We're going to dig into high blood pressure and hypertension in this episode and help folks better understand it, what it actually is and what's driving it, and what are the best practice interventions that we have available to us today. So maybe right at the top here, we can define our terms a little bit, because hypertension is going to come up quite a bit. When we say hypertension, what exactly do we mean?
The one thing we've learned from many years of observation is that there's no such thing as hypertension. So when we say someone has hypertension or doesn't have hypertension, we're really drawing a line in the sand where no physical line should exist, because the relationship of blood pressure to outcomes, whether it's heart attacks, stroke, heart failure, kidney disease, peripheral circulation problems, no matter what it is, the relationship is graded. So the worse your blood pressure, the more likely an outcome. And you have to get way down to an upper number of about 115 in order to feel reasonably safe that blood pressure is unlikely to cause a problem in your next 5 to 10 years compared to your next door neighbor who has maybe 30 points higher than you do on that upper number. But we have an agency, a group. It's called the Joint National Committee, or it's got new names now. It's called the ACC-AHA guideline. And it really isn't just the American College of Cardiology and the American Heart Association. It is an alphabet soup. And I just made this comment last week, and I think it's true. Any group that has an A, when you abbreviate their, USNA, they're likely on the current hypertension guidelines, because ACC, AHA, APNC, ASPC, and on it goes. And there's like 10 or 12 agencies that are involved here. They write a guideline and they tell us what the current definition for hypertension is. So you have to divide normal from elevated but not quite hypertensive to really hypertensive, and dang, you better do something about it. Right now, the current definition for hypertension is when your upper number is 130 or higher, or your lower number is 80 or higher. So that's the actual definition. We used to stage it so that you'd say, okay, this is bad, this is really bad, and this is, oh my gosh, have you read your life insurance policy recently to make sure your premiums are paid, and that when you die shortly from this level of blood pressure, your next of kin is going to be rewarded for that. We have lost most of the staging aspect. We now say that there's only stage 1 and stage 2 hypertension. Stage 1 is 130 to 139 or 80 to 89. Stage 2 is 140 over 90 and everything above that. So that's where our current definitions lie. And there's some semantics that we have about numbers that are lower than that, but those are the business ends. 130 seems to be our universal definition for the upper number, and 80 for the lower number.
As that top number or even bottom number on the blood pressure reading goes up, it increases our risk of kind of downstream health consequences like heart failure, like kidney disease, like having a hemorrhage in the brain or an infarction in the brain, or a blockage/infarction in the heart. And you mentioned that there is a bunch of reasons why those numbers can go up. How would you summarize what those main reasons are that would drive the blood pressure numbers up?
So years ago, we used to say, after all the work that was done, that hypertension is the geneticist's graveyard for their reputation. You would think that something as important as high blood pressure, at the current time, it's at the top of the World Health Organization's list of things that prematurely kill people or damage them so that they live with something called a disability-adjusted life year, or a DALY for short. So heredity, you would think heredity would play a big role. About 30 to 40% of hypertension we can map to family history or genes, and no single gene by and large. Rare cases of single genes, sure, and they're almost always centered about how the body handles salt. But by and large, most people do not have a single gene defect. Otherwise, we could try and fix it at some point that elevates their blood pressure. So part of it's heredity, but it's not the majority. Second thing is that we have what we call exposures over time. The Framingham study showed in the 1960s that the biggest predictor that you could measure for having hypertension later in life was how much you weighed when you were a teenager and a young adult. So people that were heavier were more likely to develop hypertension over time. And right now, that's still probably one of the biggest factors that plays a role in blood pressure elevation is body mass, index, however you measure it, whether you use the body mass index, kilograms per meter squared kind of thing, or whether you use a measure of waist circumference and height, doesn't matter. You can tell fat people tend to be fat. People that are kind of big but really muscular, they look a little different. So body weight is an important component. Some portion of the world, we don't really know the exact amount, but some portion of the world, when they eat more salt, their blood pressure is higher. When they eat less salt, their blood pressure is lower. I wish I could tell you what those numbers are. The problem with the whole salt literature, in my opinion, is that we still don't have a definition of what salt-sensitive hypertension is. How many millimeters change does there have to be in the numbers on how much milliequivalents or milligrams of sodium that equals a salt-sensitive hypertensive? And there's numbers 3, 5, 10, all sorts of things bandied about out there. So we still have a little bit of definitional problem there. But most people agree that salt intake is another aspect that raises blood pressure. The circulation likes to be exercised. So the ability to adapt to needs, especially skeletal muscle needs, which is a huge area where blood can go. When you exercise, your cardiac output, how much blood your heartbeats per minute, that can increase 4 to 6-fold in some people. And it's all going to skeletal muscle. And it's going there to rinse away the products of skeletal muscle activity like lactic acid and carbon dioxide and other things. And it does that in an amazing degree. So physical activity is one of the things that you often find in guidelines as a means to help not only defray the likelihood of developing high blood pressure in the future, but also as a component of the lifestyle approach to managing blood pressure currently. And lastly, Simon, there's a whole sidebar of things that we think are important. Potassium deficiency, for example. Most of our American diet, for example, is really high in sodium and really low in potassium. And some people would say it's not the sodium alone, it's the ratio of sodium to potassium that we get in our diet that tends to be the bad thing. So if we elevated the potassium and kept eating our Lay's, potato chips, etc., we could probably undo some of the sodium low, but I'm not recommending that as a therapy for managing blood pressure. Lastly, and the current ACC/AHA guidelines have come out in print about this, there is a role for alcohol, but boy, is it, in my mind, terribly hard to distinguish or to tease out what exactly its role in blood pressure is.
I want to step through some of those things a little more, sodium and physical activity. But before we get there, I appreciate that you were mostly going through things that are modifiable, some of the exposures that we can change through our lifestyle choices or modify over time. But in terms of the non-modifiable, if we think about age and sex, is hypertension or high blood pressure something that affects men over the age of 40 more than others? Is there differences between races? How would you summarize that?
So there are, fortunately or unfortunately, the U.S. is such a mix of Hispanic, Black American, White American, and now a growing portion of Asian and South Asian individuals, that there is a difference, men versus women. Women tend to have less because of hormonal protection until menopause, and then they surpass men. Black patients, Black Americans, tend to have more hypertension compared to white. Not a lot. I mean, this isn't like 20% versus 5%. It's like 58% versus 53%. There is always a difference, and it always, unfortunately, penalizes minority populations. That said, Hispanics, for example, have more blood pressure, but often less consequences compared to that same level of blood pressure in a white population, for example. So age affects the upper number throughout the lifespan in the U.S. Age does not affect the diastolic pressure the same way. When you look at what happens to the lower number over time, it peaks during your 50 to 55 year age bracket. Then after 55 or so, it falls. So systolic continues to rise, diastolic falls after 55, that means that the pulse pressure, the difference between the upper and the lower number, widens as you age. And one of the things we think explains that is a change in the pattern that elevates blood pressure. When you're younger, the resistance to blood flow, so how much you have to push in order to get that 2.5 ounces out into the circulation, the diastolic pressure especially tells you that it's a resistance-related thing. The body is just fighting you in terms of every heartbeat. But as you age, we learned this from the airline industry. When you take a wing and you do this to it like 10,000 times a day for like a period of months or so, much like flying an aircraft, certain stress fractures occur in the wing itself. And the same kind of stress fractures occur in the lining, in the wall of the blood vessels. You have these elastin components, especially in the aorta. And as you stretch, release repeatedly, those elastin fragments bust. Tiny bit each time. But that's cumulative because you don't repair elastin after you finish puberty. You got all the elastin you're going to have by the time you're like 15. And so you got to take care of that. And if you don't and you use it up, the body replaces that damaged elastin with a thing called collagen. If you've ever had a steak or some piece of meat that has that gristle component there, which is really hard and tough, that's collagen. And if you think about what happens when that begins to accumulate in your blood vessels, it makes them really hard to blow up with the food. And that's why the systolic pressure gets more and more difficult over time. The nature of pressure shifts from the resistance to the stiffness. And the stiffness is what drives the upper number up and the lower number down after 55. We don't know if that's truly modifiable or not. Clearly, age is not so modifiable. Gender is not so modifiable. Parental history is not so modifiable. Those are the main factors that have a role in blood pressure that we can't fix. The others we can treat to one degree or another.
Coming back to lifestyle, and I know my audience is going to be super interested in this. So you mentioned that weight loss is probably the biggest lever from a lifestyle point of view that someone can kind of pull to bring their blood pressure down. If you had to, just at a high level here, kind of rank the top 2 or 3 lifestyle levers in order, their magnitude of effect on blood pressure, weight loss being number 1, what are number 2 and number 3?
So they vary a little bit because some people are more benefited than others by some things. So let me give an example. If I have a Black American, 50% chance they're salt sensitive. If I have a white American, 20% chance they're salt sensitive. So the likelihood of blood pressure reducing by virtue of reducing sodium intake is higher in my Black American patient than it is in my white American patient. So I'm going to emphasize it more in the Black American. I'll emphasize it, but not to the same degree in the white American. So, but in general, I think that exercise is helpful as second in all for the following reason. When you exercise, a couple of things happen. Number 1, you burn calories. In order to lose weight loss, if you believe Newton's second law, I think it's the second law of thermodynamics, you can't create energy. You can just change it from one form to another. If you've got a lot of energy stored in your fat tissue, then you either reduce the intake of energy, so less calories, or you increase the usage of the energy. That's where exercise comes in. So exercise is helpful as a component to a weight loss regimen. Eating less and expending more, that's the magic in terms of a non-drug approach to weight loss. So it's good for that. Second thing exercise is good for is that it improves things like your blood sugar and your triglyceride level and the good form of cholesterol, which we call high density lipoprotein, or HDL for short. So exercise gets you a little bit better what we call profile, glucose and lipid profile, because it improves the ability of insulin to work as insulin was meant to do. Insulin helps your glucose to be stable. Insulin keeps your triglycerides in the cells, not circulating. And insulin's also good for not raising your HDL cholesterol. So when you need less insulin to do its job, your HDL cholesterol tends to be better. And for guys, one of the only things we can do to increase our HDL cholesterol is to exercise, short of drugs. And the third thing is probably, I don't know where to rank it with the other two, but exercise improves your heart rate. And the reason, I've mentioned before that the two things that damage elastin is the stretch and the number of heartbeats. If you exercise, for the time you're exercising, your heart rate goes up, but your resting heart rate comes down. That means that there's fewer heartbeats around the clock. And I think one of the other things about the pulse rate, aside from the fact that it's sort of fun to capture it on your Apple Watch or your Fitbit or your Oura Ring or whatever, is that when you look at the relationship of the heart rate to longevity, it's dang near as good as the blood pressure to longevity. So lesser heart rates, people tend to live longer. So exercise is useful for that as well. I rank alcohol fourth behind salt. So weight loss, exercise, salt, alcohol, and then potassium intake.
On exercise, Raymond, as a nephrologist and from a blood pressure perspective, do you have any views on the type of exercise that is most effective, be it, going out and doing a kind of steady state run or bike ride or doing sprints or lifting weights?
So I can tell you what I do. So this is one of those things where what does he say versus what does he do? My goal each day is 12,000 steps. And I try at least once and often twice a week to get to the gym because I see a cardiologist and he says to me, what do you do that, causes you to break into a sweat with exercise? So that's where the gym comes in. The walk doesn't, but the gym does, unless the walk's in the middle of August and it's 108 degrees outside. So I think that steps are something that mostly everybody can do. You don't have to jog. You don't have to run. But if you do steps, you're burning calories. Every time you walk a mile, you burn roughly 100 calories. And so American Heart says 8,000, but I aim for 12 because I'm interested in more than just getting my heart into better shape in terms of my resting heart rate. I'm also trying to keep my weight from doing that, older age person thing where it just kind of rises with every decade. So I aim for 12,000 steps. I hit it most days. I used to be at 15, but I just have trouble getting to that level at this point. So I don't get my extra credit points now. That takes me almost an hour and 40 minutes to 2 hours a day of walking in order to do that. But if you're going to invest in your health, it's better that than, watching some, Netflix, whatever, Amazon, whatever, some binge type of thing. So that's, when it comes to resistive exercise, like, isometrics and either bench pressing, I'm not as keen on those, mostly because I'm just I don't understand the benefits of those as much because they don't affect, if anything, they slow heart rate when you're doing them because of this Valsalva effect that people get when they weight lift or do isometrics. And there are people that believe a mix of aerobic heart rate increasing versus anaerobic heart rate reducing, like isometrics and bench pressing type things. A mix is probably a good idea. But I'm kind of the old school camp here, and I probably should be educated more about this, but I tend to do what I can do, which is to walk and try and visit the gym at least once, best case scenario, twice a week, 30 to 40 minutes at a crack when I get to the gym.
Yeah, I think that the guidelines call out a combination of both, perhaps being if someone has the time to do some of that cardiovascular exercise, the walking or jogging or whatever they can do at their level of fitness, and then some form of resistance training. And there was even things in the guidelines and some research that stood out to me that I thought was interesting. Some of those isometric exercises that people they don't need a gym or equipment to do. And I called out some of those in a previous episode, but I can perhaps put a link to that into the show notes because there are things you can do up against the wall at home or in the office without any equipment that seems to have a significant impact on blood pressure. Any advice on lowering Lp(a)? I'm young and run a lot, but it runs in my family. You can't lower Lp(a) much with lifestyle. It's mostly driven by genes. But what you can do is lower your overall risk of cardiovascular disease. And that would look like keeping ApoB as low as possible through lifestyle and or medicine. Keep your blood pressure at an optimal level of 120/80 or even a touch lower. Don't smoke or drink alcohol, ideally. Exercise like you're already doing by the sounds of it. Consider medication if you have other risk factors like suboptimal blood glucose control. And then keep an eye on new therapies. There are some new medicines that lower Lp(a) that are currently being examined in clinical trials. A side note, PCSK9 inhibitors, which lower LDL cholesterol, also lower Lp(a) by about 25 to 30%. And this is thought to partly explain why these drugs lower cardiovascular disease events. For now, they're only prescribed to people with elevated LDL cholesterol. So if you have high Lp(a) and high LDL cholesterol, speak to your doctor about PCSK9 inhibitors. They may be able to prescribe for your LDL cholesterol, and you'll get the Lp(a) lowering effect at the same time. That seems to be a sensible approach until Lp(a) lowering drug trials have been published. Another question on Lp(a), if Lp(a) is high but ApoB is normal, is cardiovascular disease certain, and do you need statins immediately? No, it's certainly not certain, but it is a red flag. High Lp(a) increases lifetime risk of cardiovascular disease even when ApoB is normal. Whether you need a statin depends on your overall risk, your age, family, your history, your coronary artery calcium score, lifestyle, etc. You may be wondering what an elevated Lp(a) is. Here's what Dr. Thomas Dayspring had to say on this in our recent episode dedicated to all things Lp(a).
As scary as Lp(a) is, which I started off the first statement, it's the most inheritable cause of atherosclerosis, is there are people with high Lp(a) who do not get atherosclerosis or aortic stenosis. If you're a clinician and you measure it and it's very high, you should assume that person is going to be at very high risk. But one day, perhaps, and I think it will come with accessory tests that we can evaluate, my God, you're the one person with very high Lp(a) we don't have to worry about. But for now, let's use what is considered you're in the danger zone or you're not with Lp(a). And there would be two sets of metrics, depending whether you're looking at milligrams per deciliter, Lp(a) mass, or molar concentrations, Lp(a) particle number. So with the mass, normal is considered under 30 milligrams per deciliter, but the guidelines will tell you you're not going to be in big trouble until it starts hitting 50 milligrams per deciliter. And maybe even when it gets to 70, that's the really high risk with but the 30 milligrams per deciliter is the 70th percentile of the human race. So that's a pretty high threshold. And, when you're starting to talk 50 and 70, you're into the 90th percentiles of what they should. They should be scary levels. So with respect to particle counts, normal would be an Lp(a) particle number under 50 nanomoles per liter. And the guidelines will, and they differ a little bit. As you said, you might see 100 nanomoles per liter, 125 nanomoles per liter as, oh my God, you're now in the high-risk territory because you're starting to approach the 80th and 90th percentiles of Lp(a) in the population.
Again, Lp(a) is a blood test you can request next time you get a blood test with your local doctor, or you can order it online with a company like Function Health. I've seen folks push back that are on the other side of this argument who would say here that lowers the nutrient density of the diet, and these analyses are based on calories, not necessarily the nutrient density of the diet. Have you looked at kind of nutrient density of individual foods or dietary patterns and their association with greenhouse gas emissions?
Yeah, so generally the metrics that we look at here are calories and protein. And for both of these nutritional aspects, the pattern I just described is true. I think it's correct that those rankings for individual foods might change if you were to pick a particular micronutrient, right? So if you were to pick iron or vitamin B12, like plant-based products just don't have vitamin B12, so you would actually just not get an answer there. So there are particular nutrients where the ranking would change. But when you start to break it down to the micronutrient level, I think it's then becomes more difficult to focus only on the comparison of one individual food, right? I think when we're talking about whole diets, it's about the combination of foods that you're eating in order to meet your nutrient requirements across the entire day or week or longer timescales. And then when you basically the point there is that you, even if particular plant-based foods are maybe deficient in one particular micronutrient or vitamin or mineral, you can build a plant-based diet that is sufficient in all of these aspects. And that diet on aggregate will still have lower land use and emissions, etc., than a more animal-based diet.
Yeah, it's a little bit like the kind of very reductionist view of comparing the amino acid or protein content of one food versus the other, when, at least in Western countries, people eat with diversity and are getting amino acids and protein from a variety of foods that complement one another and kind of ensure that someone's getting enough total amino acids and protein across the day.
I think to steel man that position, I think there are like very valid concerns. I think that in particular contexts, that's an issue, right? So like in particular contexts, I'm thinking more in lower income countries where people maybe don't have access to a wide range of foods and be able to afford a wide range of foods. Sometimes the animal-based product is the only source of a given nutrient that they have. But I think that's very different from many of the listeners that I'm speaking to or I'm writing about, where usually the choice and affordability is there to have a very varied diet. I think then the additional missing element that is very addressable, but I think is important, is then education and people understanding what combination of foods and what a complete plant-based diet would look like in order to get those nutrients.
And that also brings us to the important point of there is the data that informs what a planetary kind of friendly, healthy diet looks like. And then there are separate question is who can access that, and therefore in parts of the world where they cannot access that, it might be that there's a different dietary approach that is best, but also solutions that are needed in those parts of the world so that they can eventually access that type of diet in a way that's affordable.
And I think, not to loop it too much back into the energy space, but I think there also just needs to be some consideration for the fact that especially for people in lower income countries or people generally on low incomes that maybe are also in energy poverty and are not using a ton of fossil fuels, etc., the overall environmental impact is low. And the overall meat or dairy consumption is also low. And at those very, very low levels, it isn't a huge environmental problem. So I think that's also just important to note, is that the marginal impact of someone that's not consuming very much meat or dairy and reducing that further is very, very low in comparison to people that eat quite a lot, reducing it by a smaller relative amount.
Yeah, it's a little bit rich for us to sit here in Western countries and tell them to eat less animal foods if it was to affect the nutrient status of their diet. Totally on board with that. For those of us that are in Western countries and have access to a wide variety of foods and have the means to change our diet, is the Eat Lancet Planetary Health diet still like the resource that you would recommend people look at, or is there a different kind of dietary pattern or set of guidelines that you would refer to?
I have mixed views on the Eat Lancet diet, largely because I'm not super convinced that being extremely prescriptive on you can have X number of grams of this or X number of grams of that is particularly useful to people, or they're particularly open to that. I think many people are quite opposed to being told you can have X number of grams of this and no more. So my general recommendation is, and this is partly also trying to meet people where they are, is giving people general principles for what's most effective. And the current situation we're in on food is that these changes in overall meat and dairy consumption, actually dairy's down quite a bit in some countries, but in general meat consumption is that the stuff is not moving very quickly. And therefore, any change in a positive direction that gets the ball rolling for me is a win, right? So even if someone's reduction of a given animal product was not to the level of the Eat Lancet diet, I would still see that as a positive if they are reducing their intake. So I try to be less prescriptive of you should eat X amount and give people general principles of making this change or making this change would have a quite a substantial impact on your overall impact.
Can we step through those? So what would those general principles be, or leading swaps that people could consider that you feel, based on the data, would lead to the greatest kind of lowering of the greenhouse gas footprint of their dietary pattern?
Yeah, so the biggest one by far is to move from a animal-based diet to a completely plant-based diet, right? That's where you get the maximum gains. And there, the biggest change you would have, or if you wanted to reduce it to the maximum amount and still have a complete diet, is to switch to what I would call the very traditional plant-based products, like beans and lentils and those types of stuff, rather than the kind of meat substitute products. Generally, the meat substitute products have a slightly higher environmental impact than your kind of legumes, etc. But they have a much, much lower impact than animal products still, right? So meat substitute products are fantastic and I rely on them a lot, but kind of legumes and traditional, what I would frame as traditional plants still have a lower impact. So that complete switch is the maximum you can possibly get. But then I acknowledge that many people are not willing to do that or don't feel ready to do that now. So any general reduction in meat and dairy consumption, I would say, is generally positive for environmental impact. But the biggest, again, it's bang for your buck, even if you don't want to reduce total amount, is swaps, right, within animal-based products. And the way I generally frame this is that if you were to rank animals from kind of most environmentally impactful to least, it generally goes in size order. So at the top you have cows, so beef is generally the highest carbon footprint and land footprint, then lamb, then pork or pig meat, and then chicken and fish. So it goes from big animal to small animal. And even if you don't reduce meat consumption at all, switching from beef and lamb to fish and chicken would dramatically reduce the land footprint, but also the carbon footprint of your diet. So that's a key swap. The one caveat I'd add there is that swap is very, very positive from an environmental point of view. That swap is very negative from an animal welfare point of view. So there's a very unfortunate trade-off there where switching from beef or lamb to chicken or fish is negative for animal welfare generally. One, because you have to kill more chickens and fish to get the same amount of meat, so the number of lives cost. And then generally welfare conditions of kind of chicken and fish, especially fish farming, tend to be poorer than you'd get for a cow or a sheep. So that's the unfortunate trade-off.
Are there any other kind of unintended consequences of making those swaps with regards to the environment? I'm thinking about the ocean, whether there would be any knock-on effect, outside of emissions like ocean acidification or other things that we think about when we think about the farming of fish.
Yeah, so the one, wild fish catch, but also fish farming does have other impacts. When it comes to wild fish catch, there are just fish populations that are overfished and local populations are strained. So that partly depends on the type of fish that you are switching to and also where that is produced. It's often very hard to give. I think when I discuss this, people want to know, like, okay, tell me the fish that I can eat then. But often it depends very much on these local impacts and these local populations. So often I'll refer people to, there's usually for a given country particular guidelines and recommendations on types of fish that are less overfished and have healthier populations. So there are these negative knock-on impacts. When it comes to fish farming, it's still the case that you need to grow feed in fish farming, and sometimes wild fish are then fed to fish farms, right? So there are these other impacts to consider as well.
I think the other thing that people think about here that comes to mind is exposure to heavy metals and microplastics. Certainly, that's something I hear from people as soon as there's a recommendation to consume more seafood, given there's so much discussion around pollution in the ocean. Is that something that you've kind of come up against or seen as a counter argument here?
Not specifically in the marine context, but there's a lot of discussion more broadly just about the human health impacts of microplastics. And to be transparent, I've found the research on this very disappointing in terms of it's really just not clear what the impacts are. And there are some studies which I think have been relatively poorly done that suggest quite negative impacts, but it's really, really hard to say at this stage what the impacts of microplastics are on human health. But I'd say generally there are very clearly impacts of plastic accumulation in the ocean, but I think the reality is that we're all ingesting quite a lot of microplastics all the time. So I'm not that convinced that by eating a bit more fish, you're dramatically increasing the amount of microplastics you're consuming, because I generally think we're exposed to this stuff all the time.
Yeah, this is another example of a solution, a swap. It might not be perfect, but certainly, at least from a greenhouse gas emission point of view and tackling this problem of a warming climate, it seems to be beneficial and a step in the right direction. And look, when you step back and just look at the average diet in Western populations, most people aren't eating the recommended servings of fatty fish or fish a week anyway, which is like two or three servings. So in addition to those dietary swaps you mentioned, and you step through the animals by size and spoke about the trade-off with regards to ethics, where do animal foods like dairy and eggs sit within that conversation?
So eggs are pretty low, largely because chickens are relatively efficient and we've actually, and this again has a negative impact on animal welfare, but we've become very, very efficient at producing large chickens that we can get meat from, but also chickens that produce eggs at much higher frequency than they would in the wild. So generally the footprint of eggs is very, very low, probably lower than chicken and fish actually. Dairy is better than beef because you get a lot of milk from a single cow, but worse than chicken and fish. So it kind of sits somewhere in the middle, maybe alongside pork, where it kind of has this mid position of being better than beef and lamb from a carbon perspective, but generally worse than chicken or fish or egg.
When we're thinking about zone 2 exercise in particular and mitochondrial function, you've spoken about the exercise kind of stressing the system and you become better at burning fats at a given intensity. How does this tie into terms that people may have come across like mitochondrial biogenesis or mitochondrial density? What's actually happening within the mitochondria, Iñigo, that allows you to be better at utilizing fats?
Well, it's not just the density, right, or the number, it's the function, right? And this is why we're looking into the mechanism. So it's a mechanistic approach, right, rather than a quantifying approach of how many mitochondria you have or the density, right? And this is where we look in the study that I mentioned. We look at the mechanistics, and everywhere you look from the electron transport chain, the complexes, right? You look at the MCT1s, MCT2s, you look into the MPC, the mitochondrial pyruvate carrier, you look into oxidation of pyruvate, oxidation of fatty acids. You're looking at testing the function and the structure as well, right? And this is the important thing. It's just having all the pieces working correctly. It's like you can have two people with the same muscle mass, right? And the same, dimensions, but one person is going to be stronger than the other one. They have the same muscle mass, but the function, how those muscles work is different, right? So I always think about Anatoly using the videos of the guy goes to the gym, incredibly strong, crazy strong, yeah. Right? But I mean, compared to the guys that
he's not a big guy, like relatively.
Exactly. So it's not about the size or the density, right? It's the way his muscles function and work is incredible, but it is not about the size, right? So I use that similarity with the mitochondria.
There's some great videos of him. People can look them up. You may have seen them where he dresses up as like a cleaner in the gym. And because he's not a big guy, he puts on this like oversized kind of cleaning uniform, and he looks like he should have no business being in the gym. And he walks over where, some big dude's doing like really heavy deadlifts. And while that guy's having a rest, he kind of goes over and acts like he's cleaning, and then all of a sudden he just like lifts up that weight, like it weighs like 5 kilograms, and people obviously observing are just like losing their shit. Yeah, everyone freaks out. Anyway, worth watching. But I think those videos definitely kind of speak to the point that you're making there. Tying this story back to disease prevention. So we start doing more zone 2 exercise, and I might get you to comment on how many minutes, or remind us on the minutes per week that you think is a good base. We start doing more of that. We're getting the mitochondria functioning better, where we have some higher intensity exercise as well. We're getting better at kind of shuttling lactate, recycling it. How specifically is that tied to diabetes, for example? Like, how is that protecting us against a condition like diabetes?
Yeah, so what I believe is that, as kind of what we did in our study, we're looking at the different functions of mitochondria. And the key things here are fat oxidation and glucose utilization. And that glucose utilization is tied to the mitochondrial pyruvate carrier, which is the whole thing is part of the MLOT, the mitochondrial lactate oxidative complex, right? And from the experience, this is what I see, that someone from diabetes or pre-diabetes, as we have shown in this study, the first thing that goes is not the glut force at the peripheral level, or is not the hyperglycemia or hyperinsulinemia. The first thing that goes is what happens at mitochondria, right? And as we've seen, the MPC, the MCT1, the MCT2, the complex 1, complex 2, right? And that's the first thing that goes. And we know that exercise is the best way to stimulate mitochondria. And within exercise, from what we have learned from many years of experience, that zone 2 works. It's not the only thing, obviously, because you need high intensities. And you remind me about the VO2 max, right? That high intensity exercise is an excellent way to improve your cardiorespiratory adaptations to exercise. Therefore, your VO2 max, right? So you need that intensity as well. But we have seen, from empirical evidence that zone 2 is the one that works the best in world-class athletes, in recreational athletes, in people with type 2 diabetes, with cancer rehab. And that would be a good way to prescribe exercise for prevention. And especially these populations that usually have acquired type 2 diabetes, because that's the one thing. These mechanisms that we are studying could be an explanation why type 2 diabetes doesn't happen overnight, like cardiovascular disease or even cancer. Those are diseases that takes 20 to 25 years to show up. And during those 20 to 25 years, there are different events happening. They're not clinical yet, but they're cellular events that clearly are taking that person to develop that disease, right? So when someone is usually a type 2 diabetic, many times or most of the times represents that person hasn't exercised, has been sedentary, hasn't eaten correctly, which makes the thing worse. If you can't metabolize glucose and you have more carbohydrates, it's going to make the whole thing worse, obviously. But, in that case, you want to create sustainability, which is another thing that we need to talk about when we talk about exercise prescription. So we're prescribing one exercise. Okay, we want that exercise to be sustainable. We don't want to do magic things in 6 months or a year. We want that person can do the exercise for the rest of his or her life, right? So you need to have, it's like a diet too. You don't want to prescribe an extreme diet, that's magic things, as we know that all extreme diets work in the short term, but in the long term, 90% don't work. And what we want at the end of the day is create that sustainability between diet and exercise. So that's when it comes to exercise prescription. Zone 2, it creates that sustainability. Anybody can do that, right? And if you throw some high intensity here and there, even better, right? But if you just prescribe only high intensity exercise to those ones who haven't exercised forever, I have barely seen that sustainability happening, right? And what you usually see is like people get discouraged, get injured, and eventually they suffer. And I always say if world-class athletes, about 80 to 90% of their time of training, they train in lower intensities. They don't train high intensity in 80, 90% of the time. How can we are going to be thinking that people who haven't exercised in decades are going to do that?
I firmly see the point you're making now and the results from your recent study speaking to protecting against diabetes. If we think about diabetes, type 2 diabetes, there's this obviously very big kind of glucose intolerance component. And the bit that I'm hearing today, which seems to be what's new information to me at least, is that this is not just a problem of getting glucose into the cell, as you said, but it's further down the chain. And in the case, as you get further down, how do you get pyruvate into the mitochondria? And a big part of improving that is through stressing that system with zone 2 training. That's what I'm hearing if I was to kind of simplify it.
Yeah, any exercise could do that. Zone 2 maybe does a more refined job, right? But any kinds of exercise can do it. But again, high intensity exercise, it's probably not going to be as efficient. It will help you, but in the long term, you have to be careful with injuries, with sustainability.
So for the person, Iñigo, who does have 200 minutes a week to exercise, to cardiovascular exercise, what does that split look like? Zone 2 versus, high intensity work? And back to my earlier question, we kind of went down a different path for a bit there, but would it be more optimal to have high intensity and sort of moderate intensity in the same session or in different sessions?
I think it's definitely possible to mix it up, and I mix it up all the time myself, right? Every ride I do like a few bursts of high intensity, and it works well. And also you feel the stamina, right, of the high intensity, which is important to do. And also you have the benefits that possibly high intensity exercise, it stimulates the cardiorespiratory adaptations to exercise better than lower intensity, right? So I think it's getting the best of both worlds. But the way I try to shoot for 200 to 300 minutes. I think that, 300 is ideal minutes per week. I know it's a lot in our society, and most people can't do it. I even struggle to have many weeks 250, but I try to do that. But I try to do like 3 to 4 days a week. I like the biking, and then I do about zone 2 the beginning. Maybe halfway through I do like a burst, but not very high. But maybe towards the end I do another burst, and that's what I try to stimulate both mitochondrial function and glycolytic function as well, without the necessity of just doing only zone 2 or only high intensity, right? And it depends on the terrain, depends on where you live, right? If you live in a flat area or you go to the gym, you can do very steady. If you live in an area with very mountainous terrain, it's going to be very difficult to stay steady always, right?
So those little bursts that you do are like 5 to 10 minutes in duration, or what does a burst look like?
So, I like to do like on zone 4. I don't like to go over zone 4 and get to like near VO2 max, because I don't find that at my age and my level, I don't find it pleasant. Many other people find it really pleasant, and that's what they want. I'm just happy to have like that burst where I have to work hard, but without feeling the pain, if you would, right? But that's my own option, like other people, right? But many others, they prefer the high intensity. But yeah, I think that burst can be in the form of like a zone 4, zone 5, maybe some sprinting. Those are great because you're going to stimulate those glycolytic enzymes or those MCT4s transporters, and it's going to be great for your muscle health in general, right? You have a more robust. Why just focusing on one system when you can have a robust systems? But that being said, right, that high intensity, you just need to touch it, and just touch it, you're going to improve it, right? Well, you need to spend more time, and we still don't know why, but this is from my experience. You need to spend more time in the zone 2 area to improve there.
What are the biggest or most common questions that your patients may have when you're educating them about, hey, this is what the science shows is a healthy way to eat? And I'm presuming are you seeing patients who have a diagnosis of breast cancer. Yeah, so they've been diagnosed with breast cancer, and you're spending 90 minutes with them, and you're going through all this amazing science that informs us on like lifestyle choices that can help improve their outcomes. You talk to them about nutrition and this plant-rich dietary approach. What are the main questions they have, or obstacles or concerns that might kind of pop up?
So the funniest thing they all say when they come, they tell me two things. I stopped drinking coffee, and I always chuckle because I'm like, well, you can have that back. So right off, they like me, right? I'm like, you can absolutely have that back. It's so interesting, though, because people think coffee is something they should stop, right? And coffee is always linked to living longer on Earth. It's kind of a fascinating fun fact that chlorogenic acid is such a cool molecule. And I let them have their coffee back, but I find out how they're drinking it, right? I try to make sure that they're getting a safe form of coffee. I talk about a lot of brands, like in my consult, like, hey, these are some safe brands without molds. I try to get them to not put dairy in their coffee, obviously, so they can absorb that chlorogenic acid more favorably. And I really use that as kind of my stepping stone to the benefits of soy. So if they were using a cream in it, I try to flip them over to a soy milk. And soy is the biggest myth ever. And so that's the next thing.
Especially when it comes to cancer and breast cancer.
Exactly. So, right there, first question is, our first thing they come in, they say is, I stopped coffee. The next thing that's always a question is, what's the thing about soy? I avoid soy sauce. I avoid everything with soy. And I'm like, well, soy sauce wouldn't have mattered anyways, because there's really no isoflavones.
And I kind of do understand where the fear comes from, because they read something quickly online or hear something, and often the takeaway is soy contains estrogen.
Yeah.
Stay away from it if you have hormonal cancer or hormone-driven cancer.
And it's the total opposite. It's so exciting, the soy research, actually. And it's such a misunderstanding. And it's just from that original study decades ago that was done in rodents. And, this is that bench, meaning laboratory study, to bedside human study, is it needs to translate. And we should never do a study in the laboratory and waste that money if we know that it's not going to properly translate to human data. This is also a shout to say for all those supplements and things out there that make all these promising claims and it's only an animal research. You probably want to put the pause on that and wait until you see human studies to prove it's safe or effective, because animal studies don't always translate to what we're going to see in the human, bottom line. But we saw this really clear in the soy studies. We saw that it harmed rodents because they don't metabolize soy the way humans do. In humans, we've always seen that soy is favorable, and we could look as simple just to Asian countries. It's almost a common sense application of, could this hurt a person? Probably not, right?
And I think the more soy consumed within Asian populations, the lower the risk of breast cancer, certainly if it's early life soy consumption.
That's exactly right. And then you look at urban China, where it's been industrialized, more Western diets, and we see that you have that uptick of cancer. Now, the American Cancer Society's 2022 update on nutrition and physical exercise by Rock and colleagues, perfect publication, dedicated 3 paragraphs to soy. Done. I mean, I refer every patient there, every doctor there from across the country who is still telling their patients not to consume soy. And there was a beautiful meta-analysis done that showed that after breast cancer diagnosis, those women who have more soy versus those that don't had a 25% reduced risk of breast cancer returning. That was most prevalent among women with estrogen receptor negative breast cancers, but the benefit was still seen among estrogen receptor positive breast cancers. So not only is it safe, it's beneficial. This was a statistically sound result. The confidence interval was solid. And that's where I love being in this space with lifestyle medicine, because you've got to really read the data. You got to look at this confidence interval, make sure that this isn't just happening by chance, and this is a real statistical impact, and it is without a question or a doubt. And there has been study after study after study that supports this.
And the mechanism comes back to where those polyphenols bind to?
Exactly.
Okay.
Exactly. It binds most preferentially with like a 300-fold affinity to the estrogen receptor beta, which is the anti-proliferative signal. It's so cool. So it's turning off proliferation. And the other thing is the majority of my patients, 75% of women with breast cancer have estrogen receptor positive breast cancer. So that means these women are going to go on to be on, in most situations, anti-hormone, anti-estrogen drugs. They feel kind of miserable, a lot of them. They have hot flashes, they feel achy. And my women typically do really good on the plant-based diet supplemented with soy. Neil Barnard's done cool research to show a half a cup of edamame a day reduces moderate to severe hot flashes by 88%, another study up to 92%. That's remarkable. And that is the first thing I use for my patients. Now, I have had colleagues say, well, Dawn, that's really not guideline-driven medicine, and it makes me want to go a little nuts when I hear that, right?
That hasn't made its way into the guidelines yet.
Exactly. And will it? I don't know if it will. You know why? Because it's very expensive to do this research. You cannot compare with pharma research that has, millions and millions of dollars worth of study funding to try to get a drug off on the market to show these things. And at the end of the day, it's not going to hurt my patients. So why would I not use it? And so I have hundreds of women, thousands of women that have benefited from the soy. It's just so hard to get this research funded in a way that you're able to help move the guidelines, but hopefully we will. But at the end of the day, I use it as my number one way in my clinical practice to help patients, because everything we do in medicine is first do no harm. And every single pharmaceutical we use has a potential for side effect, and not necessarily harm in all cases, but side effect, and soy isn't going to have that side effect. So I have my women try to be intentional about getting 1 to 3 servings of soy a day if they don't have an allergy or an intolerance otherwise. It is an allergenic food, so some people don't tolerate it, so don't push it. I also don't want people to overdo it. They hear this and then all of a sudden they're doing 10 servings of soy a day. No. Food diversity is key, but get a little bit of soy can be really favorable.
Yeah, I think that's a valid fear, but it's a very important fear to alleviate. If you're wanting someone to adopt a more plant-rich diet, particularly if you wanted them to eat more plant protein, if you avoid soy, it makes it harder, right? Because tofu and tempeh and soy milk, they do make a plant-based diet, in my opinion, much easier to adopt than a plant-based diet that's soy-free.
100% agree. In fact, if I have a woman who can't consume soy, I think it's nearly impossible to have her on a plant-based diet, in my opinion. Now, I think that's probably not true. I probably need to be careful saying that, but in my experience, it's very hard to do that many beans and to get enough protein just from beans, especially when I'm working with cancer patients and I like my women, I go to the 1.3 to 1.6 grams per kilogram of body weight. That's where I go. If someone's on GLP-1s, they're working with weight loss doctors, but maybe they need a little bit more. And again, my preference is plant protein and getting my people to that goal. It's not with animal protein. It's not saying, hey, have an extra chicken breast to hit that goal protein we're putting you on. Let's try to use plant protein to get there. And I don't try to necessarily make people plant only, but I try to get the majority of the protein coming from plants.
Let's start with some basics. What exactly is creatine? Creatine is a non-protein amino acid that the body produces, mostly in the liver, but also the pancreas and the kidneys, which plays an important role in cellular metabolism and energy production within important organs that have high energy demands, such as muscle, brain, heart, and bone tissues. Essentially, having creatine around helps cells in these tissues produce more ATP. Our cells need this ATP on hand to function optimally. About 95% of the body's creatine is found in muscle cells, and most of the remainder is found in brain, bone, and heart cells. So keeping it very, very simple, creatine is an amino acid that allows your cells to function as they should. A non-protein amino acid means that unlike amino acids like leucine and valine, which you may have heard of, creatine is not used to synthesize proteins, but rather has direct effects on physiology as an amino acid itself. The key takeaway here being that creatine is important for energy production and metabolism, and the body is able to manufacture it. In fact, the liver, pancreas, and kidneys produce about 1 gram of creatine per day from the amino acids arginine, glycine, and methionine. And the average person eating an omnivorous Western diet gets another 1 gram or so per day through animal foods such as red meat and fish, which are relatively rich in creatine. In fact, quick bit of history for you while we're here. Creatine was discovered in meat in 1832 by a French scientist, Michel Eugene Chevreul. He named it creatine from the Greek word kreis, which means meat. Because we can make creatine, it's considered non-essential, but as we will come to later, that doesn't mean that an additional intake, even above what's typically achieved with food, isn't preferred or more beneficial, so to speak. In the rare case where someone has a genetic mutation that impairs their ability to make or transport creatine, so-called creatine deficiency disorders, or CDDs. Patients typically present with delays in cognitive and physical development, speech and language disorders, cognitive dysfunction, behavioral disorders, seizures, and/or muscle weakness. When selecting a creatine monohydrate, there are a few things to consider. The first is the supplier of the creatine, not the supplement brand, but who they source from. My preference for a supplier of creatine monohydrate is Creapure, which is the most well-studied high-quality creatine monohydrate produced by a German supplier. It is the creatine monohydrate that is used in the majority of peer-reviewed creatine studies. So first things first, I'm looking for Creapure on the label. But I also go a step further these days and look for an NSF certified creatine. There's been some recent controversy where brands selling creatine, especially creatine gummies, claim to have X grams of creatine per dose, but allegedly have skimped on their formulation and instead use other ingredients that are cheaper again than creatine to improve their margins. For this reason, I personally supplement with Momentous creatine monohydrate. They use the Creapure creatine monohydrate from Germany, and their product is also NSF certified for sport, which means it's third-party tested for purity, contaminants, etc. This is the third-party testing that is recommended by the NFL, NBA, PGA, Ironman, etc., and many other organizations that are seeking to mitigate the risks of contaminated dietary supplements. If it's good enough for professional athletes, it's good enough for me. So that's the type of creatine and my recommended brand, Momentous. But what about dose? Well, this really comes down to the benefit that you are personally chasing. The strongest evidence is for 3 to 5 grams per day or 0.1 grams per kilogram per day for building strength, muscle, and improving body composition. If, as we discussed earlier, you're wanting to experiment with high-dose creatine supplementation for cognition, it is important to remember that the first 5 or so grams of creatine that you consume per day is taken up by muscle. So you need to fill that tissue up first before creatine starts to go to other tissues like brain and bone. That's why the typical dose in studies looking at increasing brain creatine levels are 10 to 30 grams of creatine per day. And then there's the dose for improving cognition on specific days after sleep deprivation, which was 0.35 grams per kilogram. For someone like me that weighs around 90 kilograms, that's roughly 30 grams of creatine, quite a high dose. Personally, my regular dose of creatine is 10 grams per day, split over 2 5-gram servings with food. I find that I tolerate that best. Why 10 grams? Well, I weigh 90 kilograms, and so using the 0.1 grams per kilogram calculation, I get to 9 grams, and then I round that up to 10 grams to make it simple, with 1 scoop providing an even 5 grams. Like the subjects in the recent sleep deprivation study, you may well be perfectly fine with a high dose of creatine in a single serve. That is something that you would need to experiment with. If for whatever reason I personally have a poor night's sleep and I have an important day of cognitive tasks, I would try and split that 30-gram dose over 2 to 3 doses, again with food. If I had a history of concussions, high stress, depression, or Alzheimer's, I would strongly consider doubling my typical daily dose to 20 grams per day. As I mentioned earlier, there's not convincing data here yet, but there's a signal to suggest that when our brain health is compromised, brain creatine levels can decline and various aspects of cognition can be improved with high-dose creatine supplementation. Importantly, 20 to 30 grams per day taken ongoing has been shown to be safe, except for people with pre-existing kidney disease. If you're healthy, you need not worry about your kidneys or liver. And no, you also do not need to worry about creatine causing hair loss. That is not an adverse effect that's well supported by evidence at all, despite what you may read online. Question 1. Does the timing of creatine monohydrate supplementation really matter? If I dose my creatine exactly 93 minutes before I train for 69 minutes, will my calves finally grow? Asking for a friend. For years, the bodybuilding community has speculated that consuming creatine close to a workout might enhance creatine uptake in skeletal muscle, in muscle like your biceps, leading to better training adaptations. The reasoning behind this is rooted in the concept of exercise hyperemia, the increased blood flow to muscles during exercise. While it sounds logical, the science doesn't strongly support this idea. The reality is that the timing of creatine supplementation doesn't seem to be, and I quote here, critically important. Once your muscle cells are saturated with creatine, which typically happens after about a month of consistent supplementation at 5 grams per day or 0.1 grams per kilogram of body weight per day, the exact timing of your intake becomes far less relevant. Think of creatine like watering a plant, something I'm not very good at. If you water it a little bit every day, the soil stays moist and the plant thrives. Now, you could obsess over exactly what time of day to water the plant, morning, afternoon, or evening, but in reality, the plant doesn't care when you water it, as long as it's able to suck up enough water from the soil over the course of the day. Similarly, your muscles really do not care when you take creatine once they're fully hydrated with it. Consistency is the key. If there is any advantage to timing, it's likely small and reserved for those who are inconsistent with their supplementation. In other words, those who have not fully saturated their muscle cells. Based on basic physiology, one could speculate that taking creatine about 1.5 to 2 hours before a workout might offer a slight benefit, as this aligns the peak blood creatine levels with the increased blood flow to muscles during exercise. However, for most people, this is a case of majoring in the minors. Unless you're someone that always forgets to supplement with creatine, and so your muscle cells are not fully saturated with creatine during your workouts, I wouldn't give the timing of your creatine consumption too much attention. Next question is from Carmen. I started taking creatine and my kidney markers went out of whack. Why? Okay, this actually is not that uncommon, and it's almost always a false positive. Creatine gets broken down into creatinine, so not to be confused with each other, creatine and creatinine. You'll see creatinine on your blood test results, along with eGFR, which is a sort of an estimation of the filtration rate at your kidney. And that is calculated based off of creatinine levels. Now, in someone who is not supplementing with creatine, if you noticed elevated creatinine and lowering of this eGFR, that's a sign that they may have kidney damage. Essentially, it's a sign that the kidney is not doing a great job at filtering. But when you have this context of someone who is supplementing with creatine, you expect creatinine to go up, and it's not indicative of kidney damage. So if you go in and get a blood test and you've been supplementing with creatine, and you haven't told your doctor that you are supplementing with creatine, they could look at your results and see creatinine's elevated. And as a result, eGFR will be low because, again, creatinine is used in that estimation calculation. And they could think that you have an underlying kidney problem. But if they're a doctor who has done their research and understands the mechanisms here and what happens with creatine supplementation, then as soon as you tell them that you're supplementing with creatine, their concerns should go away. Now, if you want to be really, really sure that you don't have kidney damage, you're someone that's supplementing with creatine, ask your doctor to order cystatin C. That's a more accurate blood biomarker indicative of kidney health, kidney damage. So if your creatinine is high and your eGFR is low because you're supplementing with creatine and you just want to be sure that you don't have any kidney damage, go and order cystatin C. And if that's in the normal range, then that suggests your kidneys are functioning perfectly fine and you don't need to worry about supplementing with creatine. And just to provide a little bit of extra reassurance here, I have a quote from a recent review on creatine that addressed the claims around kidney health. And I quote, "There appears to be an unsubstantiated perspective that if the kidneys are forced to excrete higher than normal levels of creatine or creatinine, some sort of kidney overload will take place, causing kidney damage and or renal dysfunction. In reality, transient increases in blood or urinary creatine or creatinine due to creatine supplementation are unlikely to reflect a decrease in kidney function. Additionally, one must exercise caution when using blood creatinine and estimated creatinine glomerular filtration rate in individuals who consume high meat intake or supplement with creatine, end quote. So hopefully that settles your nerves with regards to creatine supplementation and your kidney function. But again, if you are concerned, go back and see your doctor, order a cystatin C test and go from there. There you have it, friends. I hope you enjoyed this episode. If you did and want to stay up to date with future episodes, be sure to hit that subscribe button on YouTube and follow on Apple or Spotify. Finally, thank you for showing up and the effort that you're making to take control of your health. I look forward to hanging out with you again in the next episode.